back to, you're saying that you use case studies more often. And I think it's important to highlight that you're not really saying like case studies are more important than like randomized control trials. Just like in these scenarios where there's no randomized control trials, or maybe they're just the evidence isn't conclusive, these case studies can be insightful into being, helpful and to perhaps steer you in a direction you wouldn't have thought of. And I think that's important to understand as well, that there's a lot of people out there doing good work, and perhaps they're asking questions that you wouldn't have thought of otherwise. And that's exactly what you're doing with your case studies.
Yeah. Yeah. And I think, for me, I thought, okay, well, I'm going to put these out there. And, again, we were always told that case studies are the lowest form of evidence. And so I would put them out there, and I would expect them to have largely no impact. And then interestingly, what I found was, as I started traveling around the country a little bit, I started hearing from clinicians, oh, I read your cases, and your cases are good, and I use them, so these case studies do have an impact, and yeah, sure, for things that are common, right? So great, let's say for patellofemoral syndrome, there's lots of RCTs on patellofemoral syndrome, and there's lots of systematic reviews on how to treat these patients, and there's the clinical practice guidelines, and okay, great. Let's say I follow all of those, and I do it exactly the way it's supposed to be, right? Well, those clinical practice guidelines don't get 100% of patients better. They get, they tell you how to get the bulk of people better, right. And what is that number? Is it 90%? Is it 95%? Is it 80%? Whatever that number is. Okay, I did all that, but now my patient isn't better. So now what? Right. Yeah. So, and that's when you have to look at, okay, well, it's not really what gets the 95% of patients better at that point. It's what, those 5% of patients that didn't get better, what gets them better? And that's when you start accessing some of the research on some of these more esoteric, niche little holes in case studies and things like that. And that's where they play a role. So I would encourage clinicians. I mean, if there are clinicians out there listening, you already have great cases. I mean, you can reach out to a mentor. I'm happy to mentor people where you can find somebody that you're familiar with that publishes. Reach out to a mentor and get those out there, because they're important to the literature, and they're important to clinicians, and they're used.
Very much so. And, you talked briefly that case studies can be super useful. And I guess other misconceptions about research that people don't understand, I guess, whether it's either at, like, starting the process of conducting research, or anything that you've run into, because you've been a part of several publications, I think 31 or so. And so I guess, are there other misconceptions that you found while doing research?
Yeah, I think there are people out there that have interest potentially in dabbling into research. And I think that it's kind of like, I don't know if there are any wine drinkers out there, or non-wine drinkers, right? But drinking wine, it takes a little bit of time, right? Like, you don't start off with, I'll talk to people that, oh, I don't like wine. I tried it once, and I'm like, what do you try? Oh, I tried a Merlot, and I'm like, well, I mean, that's probably pretty advanced for your first wine taste. Like, maybe you could start off at Riesling. Risling's a semi-sweet wine, and you get used to that over time, and maybe you move up to a Pinot Grigio, which is a bit drier but doesn't have that oaky flavor, and and then over time you work your way up to the Merlots. You don't start at Merlot. And I think research is the same way. I think there are people that are out there that are interested in contributing to research, but they don't know what that would look like. They think they have to set up the IRB and do an RCT and things like that. And maybe it doesn't need to be that way. Maybe as a clinician, you can just start off with something small, like a case vignette or a case study, which doesn't require IRB, assuming it's retrospective. Or maybe as a clinician, you can get on board with a senior researcher that's going to take the load of creating the IRB and creating the study and things like that. But you can plug in as a middle author, doing more of the execution end in the clinic. I know as an academic now, there are a lot of studies I would love to do, but I'm no longer really in the clinic primarily. So I don't have the capacity to do a lot of these clinical studies. But man, if I had a clinician that wanted to plug into me and say, hey, you can use my clinic for whatever numbers you need, just help me out with being a middle author, and I think that would be a great partnership. So essentially, I think that the misconceptions are, you don't have to start off at a Merlot. You don't have to start off at an RCT. You can plug in and you can contribute to something smaller. And then as you build your skill set, you can decide how far you want to go. And if you want to eventually, do your own RCT, you can. And if you don't, if you want to stop somewhere else, that's completely okay. I mean, I have, I don't think I'm quite at 30. I want to say I'm in the high 20s as far as publications, but I've never done an RCT. And I don't have one on the horizon immediately right now. So there's a lot of ways you can contribute that are a lesser hurdle than what I think people think of research to be.